Welcome. My name's OPAL-HK. I am founder and executive director of our Hospitalist program at the University of California, Irvine. I'm also chairman of medicine at UC Irvine. I have two very renowned colleagues that are going to join me. To my right is Dr. Javed Butler. He's at Stony Brook University. He's a cardiologist and professor of medicine and professor of cardiology. And Dr. William Ford, who's associate professor of medicine at Temple University and also practices for Abington Health, which is part of Jefferson Health.
The following audio is based on a recent live symposium with Dr. Alpesh, Dr. Javed Butler, and Dr. William T. Ford. This audio is part of a certified educational activity titled Chronic Heart Failure at the Intersection of Hospital Medicine and Cardiology, teaming up to reduce readmissions and mortality. To access the entire activity and complete the post-test, please go online to www.peerviewpress.com/QCF. A printable transcript, slides, practice aids, and other features are also available.
Let me go ahead and start. My job today is going to, for the first presentation, is really going to get into the burden of chronic heart failure in the hospital setting. And this is falling into our sweet spot. How many of you, and this is a slightly different question, but how many of you actually manage heart failure patients without a cardiologist in most of your patients? All right, so you know it's false that these patients are all on the cardiology service. This is in our sweet spot as hospitalists to be managing this. Let me take this 67-year-old. We're going to use this case through the whole presentation, and then Dr. Butler is going to have the opportunity to summarize at the end. But this 67-year-old male presents to the emergency department with worsening dyspnea, leg edema, and orthopnea for 5 days. Denies any chest pain, fever, or cough. 2 previous hospital admissions for worsening heart failure over the past year. Hospitalist service has been asked to admit this patient for additional treatment. You could see the vital signs there, the hearts and sinus rhythm, doing okay in terms of oxygenation. Sodium's a little low at 131 and potassium's a little bit high at 5.2. The EGFR is 40. BNP is 400. Echo shows an EF of 33%. There's some bibasilar RALES up the lung fields, and JVD is 11 centimeters with some Kussmaul sign. Just as a reminder, the definition of heart failure has slowly kind of continued to evolve, right? It's a complex clinical syndrome. It's progressive. It could either be from a structural or a functional impairment that involves the ventricles in terms of either filling or contractility that helps us distinguish between systolic versus diastolic. You get clinical manifestations such as shortness of breath and fluid retention. The patient's presentation could be quite variable. And it's important to note that heart failure is not synonymous with cardiomyopathy or left ventricular dysfunction, right? These things can have possible structural or functional basis for the development of the heart failure definition, right? And when we talk about heart failure today, we're talking about reduced ejection fraction or preserved ejection fraction. When we characterize it, on the left column, you'll see the classification of heart failure. Generally, reduced ejection fraction is an EF of less than or equal to 40%. And most of the clinical trials that have been out there in the world that have studied heart failure patients have really been patients with reduced EF. We know much more about that category of patients, which we also call systolic dysfunction or heart failure, if you like, and much more than we know about kind of preserved ejection fraction heart failure. If the EFs are greater than or equal to 50%, you're talking about preserved EF heart failure. The other term that we tend to use with it is diastolic heart failure. Obviously, the diagnosis can be quite challenging when you're thinking about this. Sometimes it's actually a diagnosis of exclusion in some settings when people can't figure out what's going on. On the other hand, it's important to do that. Dr. Yancey has described that there is this heart failure with preserved ejection fraction that's borderline. Borderline tends to be EFs of between 41 and 49%, whereas then you have heart failure with preserved EF that is improved. These are patients that actually have heart failure with reduced ejection fraction. If you put them on appropriate therapy, you can improve their EF. We also have other stage classifications for heart failure, right? We have the American College of Cardiology Foundation, or AHA, stages of heart failure, which go from stage A through D. And you can see they're listed here. Stage A are patients with high risk for heart failure, but without structural abnormalities or symptoms of heart failure. When you start getting to stage B, you start developing some structural heart disease. You may or may not have symptoms. When you get to stage C, you actually do have structural heart disease, and you also have some symptoms. And then stage D is refractory heart failure, right? Requiring usually some sort of intervention. That's different than our clinical classification, which is based on the New York Heart Association classification. This is stages 1 through 4 that we use. 1 is there's no limitation in physical activity. 2, there's a little bit of a limitation, slight limitation in physical activity, but they're generally comfortable at rest. And when you get to stage 3, there's marked limitation in physical activity, and you start getting worsening symptoms of heart failure. And then stage 4, you're barely able to do any physical activity. So you have different classifications, as we've mentioned. And then we have this classification of chronic versus acute decompensated heart failure, right? Where chronic heart failure describes patients that have ongoing stable symptoms of heart failure. And then you can get acute decompensated heart failure where you have your underlying chronic, and then you get acute decompensated heart failure above it. And these, could be either de novo or they could be worsening of a previously stable chronic heart failure. And obviously our goals are to manage these patients, but also to make sure that we're up on the prognostic indicators for these patients and make sure we're, putting them on the right course path. Otherwise, the course path actually looks not so good, as you can see here, right? So the natural history, Mihai Georgiadi described this very nicely from initial phase all the way out to kind of the last year, where you start seeing myocardial injury and you get normal heart rates. But, as you kind of progress through, your first episode, and then later on, you could see the impact. And this, for many people, unfortunately, 5 years is what you end up seeing. And if you're lucky, you'll be able to keep patients. But again, we know that you're going to have to do the right thing for patients. And in hospital medicine, we have great opportunities to do that, right? We get 3 or 4 or 5 days with these patients. When they come in, we can put them on the right course. And it's, many times we're changing the course of therapy for these patients, and but we need to understand how to manage them. There's about 5 million cases of heart failure in the United States, as you see there. The cost in the last 2 years of life is somewhere on the order of $150,000, and 75% of all hospitalizations occur in the last 6 months of a patient's life. So that's kind of the natural progression that you see. Now, the other thing that we've been faced with, both on a national scale, is this concept that there's about 5 million heart failure patients in the U.S., as I've mentioned, but about 1 million of them result in hospitalizations on a yearly basis. The average readmission rate for heart failure patients is somewhere around 1.23. In other words, it's somewhere around 23 or 25% of these patients will be readmitted within 30 days, and more so within a year. And these are associated with increased mortality and morbidity. The cost associated with heart failure hospitalization is on the $8,000 to $10,000 range, and we spend about $227 million a year in Medicare readmission penalties in fiscal year 2014. I'll get into this a little bit more because this is obviously important for us. This slide by Eugene Brownwald kind of talks about the discharges from hospitalization for heart failure. And you can see both for males and females, the discharges are on the rise for heart failure. Now, certainly patients are living longer. We have better medications, and so that's going to obviously impact it. But also patients are developing heart failure, as we see. So again, opportunity here. In terms of the readmission reduction program, as you all are quite aware, this started with the 2011 data, and in 2013 we were hit with the first penalty, and it started with these 3 diagnoses of heart attack, heart failure, and pneumonia. In 2014, it went to 2% penalty with those 3 diagnoses, and in 2015, it's now up to 3% penalty, but they added hip and knee replacement and COPD to this list of readmission penalties. And again, patients can come back in for whatever reason. They don't have to come in for their index hospitalization. If they even come in with a stubbed toe and they get readmitted, you're going to get dinged for it. So it is really important that we think about this. The percentage of hospitals that have been penalized is somewhere on the order of 2/3 to now even greater than 3/4 of these hospitals have been penalized. And you could see the penalties that CMS has actually gotten back is somewhere in the order of $4.25 million, in the last fiscal year. So big issues for us. We're actually making an impact in terms of the readmission curve actually right now. You're seeing a drop in readmissions occurring across at least these 3 domains so far, and across the board we might be actually making an impact a little bit in terms of national readmission rates starting to fall. But now we're also going to be assessing other disease states, as I've mentioned, so that could be an issue. The penalties, just a little bit more in terms of these penalties, so you could see that, about 60% of the hospitals actually had penalties in the 0 to 0.9% range, whereas about only 0.1% of hospitals actually had a 3% penalty. So there is variability across the board here. And then your trends in terms of readmissions that you're seeing on a national scale, you'll find that actually the trends for readmission, if you look at the graph very closely, it is actually going down, but very slowly. At the same time, you're seeing emergency room visits, slightly increasing, and certainly observation stay rates start slightly increasing. Dr. Ford is going to get into this in a lot more detail, but there are obviously risk factors that impact hospital readmissions, as you see here. And the way I like thinking about this is there are disease-specific risk factors, physician factors, patient factors, and then obviously system factors. And we've listed a few things here as it pertains to heart failure that have been proven, and that, as you're thinking about this, you might want to categorize this, especially if you're involved with leading your system to helping to improve the issues around readmissions. Now, when you get to disease-specific factors, and Dr. Ford will cover a lot of the other stuff, but when you get to disease-specific factors, one of the things that I find is whether we're actually assessing congestion really well before we let patients leave the hospital, and are we aggressive enough to manage this issue around congestion. But then there's things that many of you didn't seem like you were using, but what's the role of heart rate and blood pressure, and then electrolyte imbalance? Hyponatremia, as an example, is an independent risk factor for mortality in heart failure patients. So, are we really paying attention to some of these specific risk factors that if we correct while we have them under our control, we can actually, prevent readmissions and prevent mortality? Dr. Darmerjian published in JAMA and looked at reasons why patients are readmitted that were heart failure patients and the reasons that came back. And you could see 40 to 50% of the time they came back because the heart failure got worse, okay? But then there's a whole bunch of other reasons why these patients have come back into the hospital within 30 days. May have something or have nothing to do with the heart failure itself. So, about half of them are coming back because of the heart failure, and about half of them are coming back because of some other reason, as you see there. And then other contributors in the heart failure specific population, and certainly it impacts other diseases also, but Dietary noncompliance takes up a quarter of these reasons why they come back. Prescription noncompliance is another 24-25%. So right away, between noncompliance issues, it makes up about 50% of these issues, and then access to care and so forth. We actually did a study where we showed that if I can get patients into seeing the next provider within 2 weeks, it drastically drops the readmission risk for heart failure patients. In fact, it was such a big thing that we were able to add, NP and additional cardiology support, and opened up access issues for our primary care doctors in order to deal with our heart failure patients, because access is a really big thing. And if you're on these committees, you're going to want to make sure that you push it. The other thing is recurrent congestion. If you look at this study by Lala, it actually showed that patients within 60 days post-discharge actually had worsening of high-grade orthodema, partly because of decompensated heart failure that actually got worse. And so recurrent congestion is a real important prognostic indicator for why patients will come back into the hospital, and your assessment prior to them leaving is really key here. This was a study that showed, where these patients fall, and I wanted to make sure that people understood really that it's not just the patients with reduced EF that are at risk for ultimately developing complications and readmissions and so forth. You will see in this study about half of these patients are actually patients that have preserved EF, and so we've got to make sure that we look at the totality of heart failure patients as a whole. Optimize heart failure. Greg Fonarow published this study in JAMA. As you could see, the reasons why patients have major comorbidities in hospitalized patients with acute decompensated heart failure, and you could see some of the common conditions are diabetes and respiratory disease, but even renal insufficiency. We've learned through Optimize that if patients have renal insufficiency, their risk for morbidity and mortality is quite significant in these patients. So that's another key area that you can actually key in on is, does your patient have renal insufficiency, and do I have to do something more aggressive in these patients? And then I asked you earlier about this role of the heart rate, but you look at this study by Fox and published in Lancet that showed that heart rate above 70, these patients had more events and more hospitalizations and more deaths if their heart rate was above 70 versus below 70. So again, we're learning now that it's not just renal failure, it's not just hypotension, which we learned in Optimize, but also heart rate can also have a significant impact on risk prediction of outcomes for heart failure patients. Hyperkalemia, the data was quite strong, right? Around the role of spironolactone in managing heart failure patients, and it got really strong class 1 indications for usage in stage 3, stage 4 heart failure. But when we started these patients, and you could see around 1999, we started these patients on, and were quite aggressive in the role of spironolactone, but we also saw that hyperkalemia got worse, right? There were more patients that came back to the emergency department with hyperkalemia, and that led to not only more ED visits, but also more mortality. So again, hyperkalemia is another thing that we have to keep in the back of our minds. And, us as a hospitalist, on one side, we have this goal that we want them on RASI therapy because of the beneficial effect of RASI. On the other hand, if we're worsening hyperkalemia, how do we balance that, and how do we deal with that across the board? This shows the association, again, of aldosterone antagonists with the risk for readmission in patients that had reduced ejection fraction. And you can see patients that were on aldosterone therapy, because of the worsening hyperkalemia, there was more readmissions. And so you should be thinking, what do we do and how do we manage this? And hopefully Dr. Butler will give you some insight into this really very soon. And then hyponatremia. Hyponatremia occurs in about 11 to 30% of hospitalized patients with decompensated heart failure. Hyponatremia is a strong predictor of adverse clinical outcomes, hospital readmissions, and mortality. Hyponatremia in heart failure patients is a predictor of increased use of hospital resources. I did a large study where we looked at this, and you could see that patients that actually had hyponatremia had longer length of stays in the hospital and longer ICU length of stays. And they also had larger usage of cost in terms of resources, both in the overall hospital admission or hospital duration, as well as in the ICU. Hyponatremia contributes to all these factors. Heart failure is a complex progressive clinical syndrome, right, resulting from structural and functional impairment. It involves the filling side as well as the contractility side. There are obviously multiple drivers that drive readmissions. We've talked about the issues around congestion. We've talked about sodium. We've talked about potassium. We've talked about heart rate. We're going to get into this a little bit more. And then certainly we're focused on the quality of care of our patients. So with that, I'm going to take the opportunity to ask Dr. Butler to come up, and he's going to be talking about harnessing the clinical potential of new and emerging therapies in chronic heart failure management. Thank you.
There's a whole lot of factors that lead to poor outcomes in patients with heart failure. There are physician factors if we don't treat the patient adequately, appropriately, and optimally. There are patient factors. Obviously, we give the patients instructions and the self-care behaviors are poor. They don't follow up with their appointments, their medication regimen, their salt and diet and fluid restrictions, etc. That's a problem. Obviously, system factors are very, very complex. I practice in Long Island. There are many, many competing centers, and many patients go to multiple different centers for different comorbidities and all these interactions, and when they follow up could be very complex, and sometimes the patients are really not left with one single provider who's responsible for their care with so many people involved. But I just want to focus a little bit on the disease-specific factors right on the top, and the disease-specific factors could be kind of lumped into two categories. One is those that drive the disease itself and are amenable to targets. So worsening congestion is the number one reason why people come into the hospital with decompensated heart failure. That cardiogenic shock, low cardiac output kind of patient is relatively very rare. Less than 5% of hospitalizations for heart failure are, that sort of extreme case. Good 90-95% of the patients are just sort of recurrent congestion. Heart rate, hyponatremia, hyperkalemia, all sort of risk factors for recurrent hospitalization. And if you look at it, this list could be very, very extensive of the things that are potential risk factors for heart failure hospitalizations. Now, up until recently, over the past 2-3 decades, we have made significant strides in the management of these patients with many, many guideline-derived therapies for patients with heart failure and reduced ejection fraction. So we are talking specifically for heart failure with reduced ejection fraction and not HEF for heart failure with preserved ejection fraction. We have ACE inhibitors and beta blockers pretty much indicated across the spectrum of LV dysfunction, symptomatic or not, and mineralocorticoid receptor antagonists and diuretic for those patients who are symptomatic from class 2 to class 4, digoxin in advanced symptoms, and those, especially African-American patient, hydralazine isosorbate dinitrate. But even non-African-American patients, there's a class 2 recommendation that if they are really symptomatic on other therapies that have been given optimally, that this could be considered as an add-on. So what's the new information here today? Well, the new information is that within the past 6 months or so, there are 2 new drugs that have been approved in the US for the management of chronic heart failure. One is called Entresto, or LCZ696, which is a combination of 2 pills, sacubitril and valsartan, and it has been indicated for patients with heart failure, symptomatic class 2 to class 4, with reduced ejection fraction for reduction of cardiovascular death and heart failure hospitalization. And other drug is ivabradine, which is an inhibitor of IF channel, and it reduces the heart rate. This is pretty much the only effect that it has had on patients. Heart does not have other hemodynamic effects like blood pressure or so on and so forth. And it was also approved in April for management of symptomatic heart failure with low EF less than 35% in patients who are in sinus rhythm and have persistent heart rate greater than 70 on maximum beta blocker therapy. And on maximum beta blocker therapy is sort of the one that we need to highlight, is that this is not a replacement for beta blocker. This is people who are already on optimal beta blocker therapy, either optimal in terms of dosages or optimal in terms of this is the most that they are going to tolerate because of low blood pressure or other side effects, and their heart rate are persistently high. Then adding ivabradine is indicated in those patients. So let's take both of these drugs one by one. Let's just start with LCZ696. Chronically, what we have all worried about are the bad neurohormones in patients with heart failure. So you get accentuation of renin-angiotensin system, sympathetic nervous system, endothelin system, vasopressin system. And we have targeted all these bad neurohormonal systems, some successfully, like ACE inhibitor, aldosterone antagonists, and beta blockers, some unsuccessfully, like endothelin blockers, but the whole concept has been to downregulate or to attenuate the bad neurohormonal system. But Mother Nature already has good neurohormonal system also that they try to upregulate to balance the bad neurohormone, and that is the natriuretic peptide system. But on a relative scale, there is paucity, there is lack of the good neurohormonal system. And whatever the good neurohormones, these vasoactive peptides like ANP, BNP, CNP, adrenomedullin, all these vasoactive peptides which are produced in the body, they are then degraded by this enzyme shown here, neprilysin. So what LCZ696 is, that it's a combination of valsartan and sacubitril. Valsartan is an angiotensin II receptor antagonist, and sacubitril is an inhibitor of neprilysin. So now what you're trying to do is, rather than just inhibition of abnormal adverse neurohormonal activation, you're trying to create this balance that you're trying to attenuate the bad neurohormone and accentuate the good neurohormone to try to bring that balance. So this was studied in a large trial called Paradigm-HF trial. Over 8,000 patients were randomized. Remember that we have about 32 clinical trials with ACE inhibitors in patients with heart failure across 6 different ACE inhibitors. And all those 32 trials combined enrolled less patients than this one robust trial, Paradigm-HF, which enrolled 8,400 patients. All those trials combined enrolled about 7,000 and a few hundred patients. Patients with low ejection fraction, who were on ACE inhibitor or ARB therapy, had blood pressure greater than 95, GFR greater than 30, potassium less than 5.4, and these patients were randomized to either enalapril or the combination of valsartan and sacubitril. Head-to-head, primary endpoint was cardiovascular mortality or heart failure hospitalization, and secondary endpoint was to look at these two individually. Now, what I do want you to highlight is that we have a 30-year history of developing heart failure therapies, whether drugs or devices, which are all add-on therapy. So you initially had digoxin diuretic, and then you added ACE inhibitor, and then you added beta blocker, aldosterone antagonist, hydralazine nitrates, ICD, cardiac resynchronization therapy of biventricular pacemaker. This is the first trial ever in the heart failure space, at least, where you're not adding on a therapy, but it is a head-to-head comparison with the gold standard, which is ACE inhibitor, and try to replace the gold standard with a new therapy. So it's a fundamentally different therapy. When you see the magnitude of the effect, just remember that this is not the magnitude of the effect against placebo. This is magnitude of the effect against an active comparator. So here you see that the primary endpoint for cardiovascular death or heart failure hospitalization, there was a 20% relative risk reduction, about a 4.9% absolute risk reduction in these patients who were randomized to sacubitril or valsartan over enalapril. If you were to put this sort of in a perspective a little bit, you have relative risk reduction of about 23% with ACE inhibitor therapy, but remember ACE inhibitors were compared against placebo. There are some statistical secondary analyses done that if this drug were to be compared against placebo and there was no such thing as ACE inhibitors in the world, you're looking at about a 38% relative risk reduction. But as compared to enalapril, there was a 20% relative risk reduction with this agent. If you look at individual components of this endpoint, cardiovascular death or heart failure hospitalization, cardiovascular death alone was reduced by 20% of the same magnitude, and heart failure hospitalization was also reduced by 20% as well. Our patients don't care about cardiovascular mortality. Our patient cares about all-cause mortality. So why is cardiovascular mortality the endpoint in these trials? And obviously the answer is simple, is because if you have a drug which is affecting something in the cardiovascular system, you tend to improve cardiovascular mortality. And that drug is not going to reduce mortality related to cancers or accidents or what have you. However, having said that, all-cause mortality becomes a really important measure, because you can imagine that if a drug substantially reduces cardiovascular mortality, but there's no impact on all-cause mortality, means that non-cardiovascular mortality has gone up. And there now you have sort of started raising questions about whether there is a systematic side effect which is causing things to go in the wrong direction. In this trial, there was a significant reduction in all-cause mortality also, which was driven primarily by cardiovascular mortality. In terms of side effects, there are numerical differences between LCZ696 and enalapril. Hypotension a little bit more with LCZ696, hyperkalemia a little bit more with enalapril, rise in creatinine a little bit more with enalapril. But all in all, there were these numerical differences, but for all practical purposes, the side effect and the tolerability profile was fairly comparable. And at the bottom, the red box is for angioedema, and as again you can see, those results were pretty comparable and very low in both groups of patients. So to summarize the data from the PARADIGM-HF trial, sacubitril/valsartan combination was found to be more effective than enalapril, again, not against placebo, this is against active comparator, than enalapril in reducing the risk of cardiovascular death and heart failure hospitalization by 20%. The cardiovascular death alone was reduced by 20%. Heart failure hospitalization alone was reduced by 21% relative risk reduction, and all-cause mortality by about 16%. There was improvement in symptoms and physical limitation, and all of these benefits did occur at pretty comparable safety and tolerability profile as opposed to ACE inhibitor, including the risk of angioedema, which was comparable. So moving on from LCZ696 to our second drug, which is ivabradine. So ivabradine, the channels that ivabradine works on are these thing called funny current channels, or IF channels. This was because some electrophysiology geek person was looking at some animal models, and they found these current which they were not expecting to occur normally, and they said, that's kind of funny, and swear to God, that's how the name funny channel came to be. So these are funny channels, and this drug, ivabradine, inhibits the funny channels, which are involved in the depolarization and the heart rate. So this is a very specific drug to the sinus node, where it reduces reduces heart rate. And the beauty is that it has absolutely no effect on blood pressure. So you can give it safely, as opposed to, say, beta blockers, where you're always worried about hypotension. Here you can modulate the heart rate. This was actually a pretty interesting study, because for the longest time when the beta blocker trials came up, we were all debating whether heart rate is a risk factor or a risk marker. Should you titrate beta blockers for heart rate? That question sort of lingered for 10 years, and this trial really have put all those discussions to rest, that heart failure is not just a risk marker, but is a risk factor, because if you modulate the heart rate, you improve patients' outcome, because this drug does nothing else but modulate heart rate, as opposed to our other therapies like ACE inhibitors and beta blockers that have so many diffuse effects on the body that isolating one mechanism of action is difficult. So this was looked at in the SHIFT trial with patients low EF less than 35%, heart failure, hospitalization within the past 12 months on optimal medical therapy, who were started on 5 BID of ivabradine and targeted to higher doses to get their heart rate to less than 70. Now, the other important thing to remember here is, again, I cannot emphasize it more. This drug is not a replacement of beta blocker. Beta blocker remains the first-line therapy. This drug is for patients on optimally tolerated beta blockers who have persistent high heart rate. And again, you see a 18% reduction in the composite endpoint when this drug was given on cardiovascular death or hospitalizations for heart failure in this patient population who were otherwise fairly optimally treated. If you look at just the heart failure hospitalization risk reduction in a pre-specified endpoint, there was a 26% relative risk reduction. And if you look at reduction in mortality related to worsening heart failure, you're again looking at about a 26% relative risk reduction. So significant benefit in these patients with persistent high heart rate. Ivabradine did not reduce the cardiovascular mortality alone, so the composite endpoint was positive, but was primarily driven by heart failure hospitalizations as well as heart failure-related specific mortality. And as you can see here, ivabradine did what it was supposed to do. That is, as compared to placebo, patients on ivabradine had a mean reduction in the heart rate of about 8 to 9 beats per minute. Side effect profile, again, pretty comparable between the two groups. It's placebo versus ivabradine. Very well tolerated drug, as we discussed before. Now, the problem is that there is this issue that people who are at risk for hyperkalemia, your CKD patient, your diabetes patients, and your heart failure patients, are the very patients that require ACE inhibitor and aldosterone antagonist therapy. And the worse their disease, the worse their GFR, the worse their heart failure, the higher the need for RAS modulation, the higher the risk for hyperkalemia. And these are the patients that we systematically give lower doses of ACE inhibitor, ARB, and aldosterone antagonists, especially spironolactone or eplerenone. And then these are the patients. So there's sort of a risk mismatch that the risk is higher, but the therapy is more suboptimal in these group of patients. In fact, the cardiovascular guidelines obviously say to avoid giving MRA if your potassium is more than 5 or creatinine clearance is less than 30. And this is what I just said to you is for patients in whom we have done clinical trials. But also remember that all the ACE inhibitor, ARB, and beta blocker trials actually, as part of the inclusion criteria, systematically excluded patients who were at risk for hyperkalemia to begin with. So for a large proportion of patients, we don't even have the evidence of what to do with these patients. And for those that we do have evidence, when the potassium level goes up, we either cut down the dose of their medications or we altogether stop the medication completely. So this sort of becomes a little bit of a problem. Now, when you have an acute, sort of hyperkalemic patient, we know what to do. We give them insulin and calcium and beta agonists to sort of stabilize the situation. And that is all well and good in the emergency room. But then what is our treatment? Our treatment is to stop life-saving therapies, which is ACE, ARB, or especially spironolactone or eplerenone. We really don't have good chronic therapies. Even in the Paradigm HF trial, hyperkalemia was seen in almost 1 in 5 to 6 patients in the trial. And again, I want to highlight, this is what you got when you did treat the patients with something. The problem is that there's a lot of patients that we don't treat optimally. Now, there are 2 agents that have recently been studied. One of them have been recently approved for the treatment of chronic hyperkalemia, and the other will be reviewed by the FDA pretty soon. And the beauty here is that for the first time, it opens the option for us to use these drugs chronically with a promise that because these drugs have very good tolerability and side effect profile, that you'll be able to use these drugs chronically that will help you optimize their heart failure, CKD, and diabetes medications that can translate into good potential outcome for these patients. So one is this drug called Patiromer. Patiromer, it's a powder with the spherical beads, and it exchanges in colon calcium for potassium. Potassium is just sort of absorbed in the colon by Patiromer, and you just got to excrete it out, and it reduces potassium. Both of these agents, Patiromer and the other one that I'll discuss, ZS9, also actually by decreasing potassium in the colon suppresses or reduces your aldosterone level also, because hyperkalemia is a potent stimulator of aldosterone. So there may be more than just reducing potassium with these agents. So one of the studies that was done with that, looking at mild hyperkalemia up to 5.5 or moderate to severe hyperkalemia and OPAL-HK study with Patiromer. There was sort of initial phase where hyperkalemic patients were treated with this medication and were treated up to 4 weeks. And as you can see, there was a reduction in the potassium levels, more so in moderate to severe hyperkalemia because they have more ways to go. But at the end, sort of everybody settled in sort of the mid-4 range, whether you have mild or moderate hyperkalemia, and very beautifully it was maintained up until 4 weeks. Then what they did at 4 weeks is that they randomly assigned half the people to be withdrawn from Patiromer, and for half the patients it was continued. And as you can see, that patients who were then withdrawn and put on the placebo for the next 8 weeks, the need to lower the RAS inhibitor doses or discontinuation was significantly higher as opposed to patients who were continued on Patiromer. And at the end of the trial, the number of patients who were maintained on RAS inhibition was significantly higher in Patiromer. We're looking at almost 94-95% of the people were maintained on these agents. And these drugs are very well tolerated, so it really opens up the option of optimally treating their heart failure. This is, again, sort of the pre-specified outcome looking at hyperkalemic patients with heart failure specifically. So the OPAL-HK study that I just showed was a bigger study, CKD, heart failure, everyone, but this is the heart failure subpopulation that was studied and looked at. And as you can see, within the heart failure group as well, the drug worked very well. Adverse event, again, very well tolerated. You're talking about constipation or diarrhea at 3-4% range. 95-96% of the patients tolerated it fairly well, and most of these side effects were actually pretty comparable to placebo as well. Other things like hypomagnesemia or nausea or whatnot, again, we're talking about 2 or 3% of the patients. So unlike KXLA, this is really well tolerated, and you can use it in a chronic setting. And the other agent is ZS9, which will be reviewed by the FDA pretty soon. So we are hoping that there will be not one but two options for our patients. This is a crystalline compound that exchanges, again, potassium, binds the potassium, exchanges with sodium, and excretes potassium from the GI tract. Both of these compounds, by the way, do not get absorbed by the GI, so there is no systemic toxicity per se. They just bind the potassium in the GI tract, and then you excrete these drugs out. And again, we can see the same pattern. When ZS9 was given at a 5-gram dose or 10-gram dose, you can see that patients who were hyperkalemic to begin with, there was a dose-dependent decrease in the potassium levels for these patients, with higher dose reducing it more. And again, if you look at hyperkalemic heart failure patients, potassium levels came down with ZS fairly well. You can see that there was a dose-dependent reduction in potassium levels. And there's another study, harmonized HF sub-study, looking at the serum potassium levels over time. This is hours. This is over time in days, long term. Again, you can see 5-gram, 10-gram, and 15-gram very well. Potassium levels were lowered in these patients chronically. So again, the point that I want to make here is just to note that this is in hours. So when you give the ZS9, you're talking about potassium levels really coming down very rapidly in 2 to 4 hours. And then this has been maintained. Now there are 2 studies showing that up to 52 weeks, these drugs are very well tolerated and you can maintain hypokalemia.
So as we talked about earlier, there's many factors which really contribute to the poor transitions of care to our patient population. Again, not just with congestive heart failure, but across disease states. The factors that I'd like to focus on for the next few moments really is just either the system factors, the purple section there, and the physician factors. I'm the regional director for our health system, and I pressure the directors in our groups and our docs themselves to discharge these patients. We're focusing on length of stay, but I think we're now coming to a point in our group's maturity, and even as a specialty, where we might have to balance that with appropriate diuresis, maybe 1 extra day, so the patient doesn't quote unquote bounce back. But for those of you who do look at the literature, even beyond the medical management, it's really the communication or the next handoff to that next stage of care, whether it be to a SNFist, to a long-term care facility, or to the patient's primary care physician, really that does lead to readmissions and decrease morbidity or increase morbidity and mortality. And then system factors, there's no bad hospitalists. You know, we're all seeing 16 to 1 million patients a day. We all want to get home. You know, how do we call 30 primary care physicians on the phone to improve this transition? And we'll talk about some potential techniques to help solve that problem. And if anyone does have a solution that's solved it, you know, please raise your hand. I'd love to talk to you here live on stage. So again, we'll just define the problem. You know, as Dr. Amin had pointed out, 25% of patients with congestive heart failure will come back within 30 days. That's been shown again and again. And 50% will come back in within 6 months. There's real financial ramifications, you know, now that the Affordable Care Act and readmission rates and penalties are really starting to materialize. And we'll get into why that really affects us as hospitalists beyond just the right thing to do for our patient population. So why should we care? Other than it is the right thing to do for our patients, there's a few factors. So we are starting to align the economic incentives of our hospitals with that of our individual physicians. And we get sued. So there's a few studies that actually show transition. Our greatest vulnerability as a specialty is really our transitioning the patients from the hospital setting to the outpatient setting. And that's usually where we screw up. We don't call the primary care physician, so there's real incentive for us beyond the right thing to do for the patient to get our patients transitioned to the outpatient world appropriately. And for those of you who have been practicing for quite some time, we're in the 20th year of our specialty. I love hearing the excuses from my docs on why they don't call their primary care physician or don't try to communicate with that PCP. I'm too busy. Why is it important? I actually had one of my physicians in a practice say, Obamacare hasn't gone into effect yet. Why should I call? Or we're understaffed. These excuses really should not be commonplace, or we should not be accepting them as commonplace any longer. So if you look at the literature out there, one of the major, I think, responsibilities of why this isn't catching on as quickly as it should from within hospital medicine is communication. And who's responsible for that communication? There's no one way to communicate with either primary care physician or the patients themselves post-discharge, and that is an area of grave concern. So role ambiguity is what it's called in the literature. How do we assign the responsibility of our hospitalists, of our primary care physicians? For those of you who have actually called the primary care physicians, how many have gotten, why are you calling me? Or one doctor in one practice will say, thank you for calling. The other doctor says, you don't need to call me, just call the secretary or call my nurse. So you're stuck on hold. The doctor's in the room with a primary care patient, and it's 6 minutes per call. If you're discharging 10 people, it just adds up quickly. So there are barriers to role ambiguity, such as who actually assigns the responsibility of the calling doctor, of the accepting doctor. It typically is someone above the division head, above even the chairman. It comes chief medical officers, VPMAs in health systems to actually assign the responsibility of these are the expectations of we as hospitalists, and these are the expectations that will be the primary care physicians. And some of the excuses, why don't I call my primary care physician for my docs? The line is always busy. That's my favorite. Or I don't have time, or you're always in with a patient. And again, we have to try, because if we don't try, we'll never improve this huge area, I think, of an accountability issue and how we improve transitions of care. So some strategies. So here are potential answers. I don't think there's one solution that fits all, but I think we have to try to identify ones that do fit for our own groups. There's transitional care interventions such as how do you actually treat the patient when you're discharging them? What I mean by that is a teach-back technique. How do you get them to understand what medications they should be going home on? Discharge planning, particularly with heart failure. We have heart failure nurses, heart failure staff to try to make sure that they take their diuretics when they go home and improve the readmission rate and the transition that way. Then there's some structured follow-up programs. For those of you who haven't heard, the BOOST project, which was initiated by the Society of Hospital Medicine, we'll show in a minute, and then the RED program, which I believe is from Boston University, or a re-engineering of the discharge process. And then there's just an amalgamation of different techniques under classification of intensity for our follow-up with our patients with congestive heart failure. So just quickly, I'd like to go over just the BOOST. So BOOST again was started. I think it was 2010. I think it was initially rolled out, and it's a comprehensive package, if you will, or a mentored program where an individual health system or hospital will partner with a group that's already implemented it within their institution. It's a comprehensive tool which includes 72-hour feedback, patient discharge process techniques such as universal patient checklists to make sure they understand their discharge instructions and medications. Then there's Project RED, which is the re-engineering of discharge. This was from Boston University, and it looked at the way in which we discharge our patients. There's evidence to support the actual education of our patients with congestive heart failure improves the discharge process. So with the strategic implementation of either teach-back techniques or other processes, you can find between an 8 and 30% reduction in all-cause readmissions and ED visits. Utilization of a telephone-only strategy, where if a patient is discharged home and you have a call within 72 hours to get them to see the primary care physician, wasn't as efficacious, although there was a slight improvement. Early physician follow-up and the home call is probably one of our biggest tools to improve to transitions of care and readmissions. However, the patient must be seen within 1 week in order to have this technique as useful as it can be. And then the highly intensive interventions, such as home visits, home nurses, and the scheduled follow-up appointments with also home calls. Of all of the strategies was the best implemented. And again, the high-intensity intervention, regardless of how long the intervention was done. So it could be a 6-month follow-up, 2-month follow-up, had the most benefits in this study. And moderate levels of intervention, meaning a telephone call coupled either with a home visiting nurse or a discharge process within 1 week, had to be continued for almost 6 months, that level of monitoring, to show the same benefit as a high-intensity intervention. So what are we doing at Abington Jefferson Health in the Philadelphia area? We have weight management, daily weights that are monitored when the patient is post-discharge from the inpatient institution, as well as care managers will reach out to this patient population to ensure they have a scheduled follow-up with either their heart failure or their primary care physician within 1 week. And then we actually have physician reviewers, because in some regards it is a game. So when patients are admitted to hospitals as short of breath, as hospitalists we often say heart failure. If they have a history of heart failure, that often isn't the case. They could be an acute renal failure, which isn't actually heart failure. So we actually have a panel of reviewers, of cardiologists and pulmonologists who look at this data in order to have the right classification when patients are discharged. We often struggle with how do we reach out to our primary care offices. Some doctors like to call, some doctors like to get auto faxes of discharge summaries. I've found, at least in the 17 years that I've practiced, we've tried multiple methods to solve this problem. Secure texting, there's multiple apps, is probably the one that is most useful in our practice. The challenge is getting everyone in the health system to employ that one texting system. Telephone calls would end up bogging you down for enormous amounts of time. At least with a texting method, it does enable at least the basic transfer of information to the primary care physician and the cardiologist. Something that as hospitalists, my group, this past 6 months, we've rolled this out, was the teach-back technique. It was new to us. It was exciting to hear that a majority of the groups here tonight do employ this, but it really makes you stop for a moment. And when you talk to your patients and you say, take these 15 medications, and they shake their head, and you think they understand, and then you ask them to repeat it back, it's enlightening that they have no idea what you're talking to them about, particularly if they don't have a family member or someone else with them. So we did roll it out to our group this past year. We did it in a stepwise fashion. We let everyone know it was coming. We did some role play. Patients, I think they just shake their head because they're so excited, they're feeling better, and they want to go home. They really need to understand this diagnosis because it's very complex. And some of the issues to remember, that transitioning patients in a health system, it's a hospitalist responsibility, almost by the definition of our name. As hospitalists, we need to own this. And as many of our groups are becoming more and more influential in health systems in large, we need to help leverage the organizational strategy to really assign responsibility, not just within our group, because we're always told whatever problem jumps up in a health system, it's the hospitalist role to solve it. We do need help to assign responsibility on how we should do this from an organized fashion, not just please communicate better. I think you need organized strategies on how to accomplish that. Again, techniques to improve transitions to care, whatever works for your group, but I think we need to really try to improve because it's an economic burden, both on just readmissions, but also for patient satisfaction and the economic burden to us as hospitalists. And then utilizing outpatient follow-up. These are all really intertwined areas of interest for all hospitalists, whether it be transitions of care, communication to the primary care physician, communication to families. Hospital caregivers really need to ensure that patients with congestive heart failure particularly need to follow up within 1 week. How your individual groups operationalize that, I think, is on an individual basis, but it should be of primary importance. One of the things that we as hospitalists have been struggling with over the years is lower length of stay, as I mentioned earlier. I think this does need to be weighted in the fact of if you get them out too quick and they come back in 5 days, I think we're defeating the purpose of our patient strategies. So maybe the trade-off of 1 extra day to diurese with good communication and transition to the primary care physician team, I think is a needed strategy. And then finally, real-time feedback for those of the directors in the group, real-time feedback to our constituents or to our hospitalists is paramount because just to say do better without real-time data it is something that really is going to fall on deaf ears. So in my group, we have our cardiology heart failure team that meets with our hospitalists, and we review our Crimson data, which is real time. We usually do it within a month to 2 months lag, which is pretty good for most health systems. And it does give our physicians time to realize that the teach-back technique that we rolled out, maybe it has an impact, maybe it doesn't. But I think without a strategy of feedback to our physicians, it's very challenging.
I wanted to give Dr. Butler a chance to tell us how he would actually manage this patient that you've been watching through this presentation.
So just let me make a couple of very relevant points for hospital medicine colleagues related to the 2 new drugs that have been approved. So one is the one drug that we talked about, the combination of valsartan and sacubitril. Entresto is contraindicated to be used in patients who are taking ACE inhibitors. Remember that this is a therapy to replace ACE inhibitors. Using Entresto in combination with ACE inhibitors significantly increases the risk of angioedema if they're used together, not individually. Therefore, the recommendation is that there should be a 36-hour washout period off of ACE inhibitor before you start sacubitril and valsartan. The reason why this becomes a very important issue for you all is that if your hospital formulary doesn't have this drug yet, but a doctor has prescribed it as an outpatient and the patient comes into the hospital for any reason, either heart failure or pneumonia or whatever, gallbladder, that you might have some automatic way, order said that you stop sacubitril and valsartan and start ACE inhibitor right away, and the patient may have just taken Entresto a couple of hours before that, certainly not 36 hours. So you have 2 options, either to stop Entresto because you don't have it available in the hospital and start it after 36 hours of hospitalization. That's one option. If your hospital allows and if you so wish, you can have the patient continue their own medication from outpatient. Or the third is that you can switch them to an ARB. So it doesn't matter. The combination of valsartan and sacubitril has valsartan in it. If you switch valsartan to candesartan or losartan, that's no problem at all. But if you were to switch them to something, switch them to an ARB, not an ACE inhibitor. You have to have a 36-hour break between the 2. So that's the LCZ part. Now on the ivabradine part, a very relevant issue to the hospital medicine is that actually the FDA has given a contraindication for use of ivabradine in patients with acute decompensated heart failure. And the concern there is that there is a general practice, although these are observational data, we don't really have good clinical trial data, but the observational data are that a lot of us is stop or reduce the dose of beta blocker when people come in with decompensated heart failure. Obviously, if somebody is bradycardic or is in cardiogenic shock, you want to do that. But most of the time, you actually don't need to touch their beta blocker dose. Having said that, most of the time we do reduce beta blockers. And there is a real worry that what will end up happening is that because ivabradine does not have a blood pressure lowering effect, and now we have lowered the dose of beta blocker, somewhere during the hospitalization or at the time of discharge, we will think of ivabradine as another beta blocker and just put them on ivabradine, and now the patient will never get optimal doses of beta blocker. So that's another thing to remember, is to not lower the dose of beta blocker unless there's a very good reason, and that ivabradine is on top of optimal beta blocker, but not instead of. So these are 2 hospital medicine sort of related comments that I want to talk about. Now, if you look at this patient, this patient, has blood pressure, which is kind of borderline, not bad, but not necessarily 140s. His creatinine is borderline also, GFR about 40, so it's not GFR 15, but not great. And potassium is not 6, but 5.2, again, sort of high for comfort. And the question is, what do you do for this person for long-term management? Well, so this person sort of fulfills all the drugs that we talked about in our earlier discussion. He's already on optimal doses, 20 milligrams a day. Switching this patient from enalapril to LCZ696 or a combination of valsartan and sacubitril would be a good idea. The things that you have to worry about, again, this person is already on ACE inhibitor. So when you switch ACE inhibitor to this, you don't expect the hyperkalemia or hypotension or renal function to get worse. That is the concern you have with all RAS modulators when they are naive of RAS inhibitors and you're just starting. But since here you're switching, you can expect that the patient probably will do okay, but you'll start at lower doses and you will move up. There are 3 doses of sacubitril and valsartan available: low, medium, high, 50, 100, 200, and you can do that. If this person is on 25 BID of carvedilol, which is a maximum dose of beta blocker, and this person is clearly not doing well, has a heart rate in the 90s and has been hospitalized for a couple of times over the past year, so clearly would be a very good candidate for the use of ivabradine. Again, ivabradine, you have to be in normal sinus rhythm. You don't give it when somebody is in atrial fibrillation. And then the last issue is that technically speaking, per the guidelines, you cannot use spironolactone 25 milligram if your potassium is already 5.2. So either you need to figure out another way of reducing potassium or cut down the dose of spironolactone or stop the spironolactone altogether. For the first time, we have the option with 2 agents, one approved by the FDA, other hopefully soon, ZS9 and Patiromer, that we can manage these kind of patients with chronically management of their hyperkalemia and optimization of RAS therapy.
Great, thank you. So just in terms of the ivermectin, one of the questions that came up by the audience is, do you ever see a potential day when it might be used in hypotension in patients with lower blood pressure because you can't use a beta blocker and you're trying to control the heart rate?
Yeah, so I mean, that day is today, right? So I mean, if you are on optimal therapy for beta blocker, which is either guideline-derived doses or intolerability of higher doses, and there's persistent high heart rate, absolutely. You can use it today. So if somebody's blood pressure is 90 and they're on 12.5 BID of carvedilol and they're a little bit dizzy and there's no way you're going to go to 25, you can use ivermectin today if the heart rate is more than 70.
Great. Dr. Ford, how important is fluid restriction in patients with heart failure?
This question is with respect to transition the patients from a fluid restriction for heart failure inpatient to outpatient. You have to get nutrition and the heart failure team for those end-stage heart failure, but particularly nutrition to educate the patients. One of the big things, particularly if they're not able to cook for themselves, we often have our clinical nurses ask, who does the cooking? Because to go over a diet and fluid restriction and those recommendations to a patient who isn't going to be the primary food giver, if you will, or who's responsible for the meals is useless. So we often get that on early. We have a great heart failure team who will address that usually day 1 or day 2, and then that transitions over to the patient's discharge instructions. When do we transition from IV to oral diuretics? Obviously from when the patient's clinically stable, we transition from the IV to the oral. And then if the patient's medications have changed, that's one of the major things that we go over. Our clinical care coordinators and our doctors will all review that prior to the discharge. And then I wish we said we communicated every medication change to the primary care doctor, but I'd be lying, if I said we did that on every patient. We should, but it's a challenge.
So the question about the IV to oral switching of the diuretic, do we have to give patients 24 hours of time before we can let them out of the hospital?
From my perspective, no. I mean, as soon as they're ready for oral, they can go home. Now, whether there's data supporting that, that then translates to increased readmissions, I think the jury's still out. But I typically do not keep them for that extra day once they're on oral.
Yeah. So I think the question that they're trying to also get at is this issue about congestion, right? Because, one of the things that we kind of need to spend some time really addressing is, it's not just whether you're able to switch them from IV to oral and so forth, but it really is, did we get rid of the congestion or as close to being able to manage the congestion issue? Because from a readmission perspective, if the congestion is still there, there's a pretty good likelihood that the patients are going to come back into the hospital. For Entresto, why did they compare it against enalapril as opposed to valsartan?
This is a drug that has a combination of sacubitril, valsartan. So the question is very well taken, because if you were to compare sacubitril, valsartan to valsartan, then whatever the benefit is of this new molecule sacubitril, then you would have known. And now we don't know that. And the reason for that is that there are, as we discussed, 32 trials with ACE inhibitors in patients with heart failure and about 4 trials with ARBs. We are pretty comfortable to say that if somebody is ACE inhibitor intolerant, that they can take ARB. But every guideline out there for heart failure, whether it's Canadian, European, or US, it specifically says that the first-line therapy for heart failure is ACE inhibitors, and if ACE inhibitors are not tolerated, then use angiotensin receptor blockers. So you can imagine that if I were to come and present the data today and show that Entresto had a 20% mortality benefit on cardiovascular mortality benefit on top of valsartan, the first thing people would have said, so what? The standard of care is ACE inhibitor, and you did not compare it against ACE inhibitor. So it was very important to compare it against ACE inhibitor in that sense.
There's a couple of questions here centered around sodium and what do you do in terms of the sodium if it's at 125 to 130 range? Because I mentioned earlier that hyponatremia is a risk factor, an independent risk factor for mortality for heart failure patients. So I'll just take that really quick and say to you all that, you do want to try to resolve the hyponatremia as best as you can while they're in the hospital. It gets more challenging since our length of stays are continuing to get crunched. But there are therapies that will help with the sodium issue also. For example, the V1, V2 receptor blockers. Tolvaptan is the oral agent, and there's both conivaptan and tolvaptan. So the V1, V2 receptor blockers can be used in patients that you can't quite control the sodium and get the sodium up, and their results are quite good in terms of it helping to transition patients to the outpatient setting. So if you try diet, you try fluid restriction, you try those types of things while they're in the hospital, you try your diuretics, and as long as it doesn't get worse, and then you can the V1, V2 receptor blockers are also opportunities for dealing with the sodium. And the advantage of the tolvaptan is that you can actually, it's oral, so you can actually discharge them on that and follow them as an outpatient. I would also just make the comment that, starting them in the hospital is important because you want to make sure that the sodium, you don't have the issues around osmotic diuresis, which is, a concern in and of itself. Do you keep patients in the hospital unless the heart rate is below 70 now today in 2016 March, or what do you do?
I do not. Yeah, so if they're resting comfortably and they're at 85, 80, they go home. Even being part of the panel, I learned like you all, I'm not going to keep them there an extra 3 days to get their heart rate down. Maybe a strategy we could employ is they get a follow-up appointment in a day, with their primary care doctor, because I think the jury's out on that. If they're seen that week and it slowly goes down, that it's the same, whether they sit in the bed or they sit in their own bed at home, but as long as they have good follow-up, if someone's 75 or 80, they're going home.
I completely agree. Again, in the clinical trial, this was a chronic heart failure trial where the drugs were up-titrated over weeks. So this is not acute management. Right. But again, starting in the hospital does have some benefit, and you have the advantage that you have more time with the patient to talk as opposed to in the outpatient setting, but clearly no reason to keep them in the hospital just to lower their heart rate.
And I think it does emphasize really the role of transitioning these patients. I think even, again, for myself, from an educational perspective, to identify these patients who are higher risk for readmissions, I think that really drives the point home. They need to be seen within the next 72 hours to a week. And there's financial incentives for the primary care doctors, as we know, with the new codings for patients who are seen post-discharge. So there's incentives for everyone, including the patient, to be seen.
So just one last comment on that issue. Remember, the goal here is not necessarily whether you're keeping them in the hospital or managing them as an outpatient, but the issue is that we have some key indicators that can help us in terms of realizing whether we are actually managing our heart failure patients to the optimal level that we want to be able to manage them to, right? And so the potassium is a key indicator, the sodium can be a key indicator, the blood pressure can be a key indicator, the heart rate can be a key indicator. So as you work on transitioning these patients from your service to the PCP, the outpatient cardiologist, the outpatient nurse practitioner, if you haven't totally optimized these things, what you want to do is make sure that the baton is carried by the next person, obviously, and that there is a continuous follow-up so that these key indicators are ultimately resolved as best as they can, because if they're not, chances are you're going to see them back in the hospital. So that's the important point. We're talking about risk stratification and risk prediction, if you like, here. The question about cardiac rehab and its role in facilitating transition of care for heart failure patients.
Yeah, so for the longest time, we all believed that cardiac rehab is really good for patients with heart failure, but the problem was that unlike myocardial infarction or CABG or PCI, where it was covered by Medicare for heart failure that was not an indication and it was not covered, so it was tough to get cardiac rehab. So finally, we did sort of a large multi-center trial called HF Action that basically showed that cardiac rehab in patients at high risk, which was basically defined as post-discharge patients, if you refer them for cardiac rehab, there was almost a dose-dependent improvement in patients' outcomes and quality of life, and the more they were able to exercise and they adhered to the regimen. And all of this eventually led to an approval by the CMS of heart failure as an indication for cardiac rehabilitation. The amazing thing is that the community, although we have all complained for the very long time of heart failure not being reimbursed, now that it is being reimbursed as an indication by CMS, the uptake has been incredibly small, and we're just not referring our patients for cardiac rehabilitation. So there's a lot of initiatives right now going on to actually increase the referral for patients with low ejection fraction for cardiac rehabilitation. The trial for heart failure with preserved ejection fraction and the impact on cardiac rehabilitation is funded by the NIH and is ongoing right now, but I don't have the results. But for low EF, cardiac rehab has been shown to improve outcome and is paid for by Medicare. All it needs is for us to refer the patients.
Dr. Ford, any additional
From
comments?
a cardiac rehab perspective, I don't necessarily, as well, just specifically transfer those patients to cardiac rehab. But as many of you know, your 85-year-old patient with an EF of 30%, any rehab, they're usually going. And I find, consult social worker, case manager for rehab placement. I mean, how many times do you say that during a day? I find that patient population tends to be elderly with a large burden of new medications or additional medications, needs a couple extra days before they're able to transition home. So I do utilize general, skilled nursing facility prior.
I wanted to thank the Hospital Quality Foundation for its support and help in terms of organizing this, and also Peer Review for their support and help in organizing this event. So thank you for staying after. Enjoy your time.
Thank you for listening to this activity. To view the rest of the CME activity, download materials, and complete the post-test for instant credit, please go online to www.peerreviewpress.com/QCF. This activity is supported by an educational donation provided by Amgen Incorporated and educational grants from Novartis Pharmaceuticals Corporation, Relipsa Incorporated, and ZS Pharma Incorporated.